All right, next up is Lisa Bruening, and she's going to be talking on guidelines for healthcare professionals working with individuals with complex communication needs.
Thank you, Sarah. Whew, thank you, everyone, for being here and being here after lunch, and thanks to the Alliance for accepting this presentation. It's so lovely to be back in person, to see faces, even with the blinding spotlights. I can see shadows. And to all our friends that are online and virtual, hopefully we'll see you all next year. And I miss seeing your faces in the little boxes, like the Brady Bunch. And our friends at home, as Amber mentioned earlier, are still having their watch party after 5 p.m., so thank you for the dedication of my team back home. So this presentation came out of many years of my work at the ALS Association Northern Ohio chapter. I'm a speech pathologist, and even before that, thinking, like many of you in the room probably already know all this, but I'm hoping there'll be some nuggets and some guidelines that you'll be able to take home and share with your teams, even in nursing homes, in home care settings, any of the respite places. Because what we see is that just because we are used to people using multiple modalities for communication, many people don't know what to do and how to interact with somebody who has a speaking challenge. Maybe their voice is dysarthric, and then they interact in very inappropriate ways. So if somebody can't speak, you notice that the listener would maybe start speaking louder to them, or getting closer to them, or using very wide gestures. And even in our healthcare professionals that we interact with all the time, we were doing a communication device assessment, and the rep that was there kept getting louder and louder and louder and talking to this woman. And she's looking at me in her very dysarthric speech saying, "Why does he keep talking to me like that?" And I couldn't help but laugh. I'm like, and so he's like, "What is she saying?" And I'm like, she wants you to not yell at her. So, but again, he brought it back down and still kept continuing up. So it may come as no surprise to most of us in this room that many healthcare professionals have limited experience with augmentative and alternative communication strategies. And when communication struggles exist, obviously, then the patient safety is at risk. We could all benefit from some, and I know Lisa's going to do a lot of this tomorrow, many different strategies in how to communicate and how to watch for signals, and that hopefully you can take these strategies home and share with your teams. So this is where I'm from. So those not from the United States, I'm from Ohio. We call that on our north coast. And our chapter serves the northern half of Ohio. We have about 300 families, persons living with ALS at any one time, and serve about 450 people per year. We have a team of 5 people in our care services department, and 3 social workers, a nurse, and myself. So for those of you who have known me for a while, it's amazing. We have more than just 2 people helping our 300 people. So thanks to all of them. I'm so amazed at how much we're able to do now. The other piece, as we've already heard so many times today, and I swear that my colleague and I did not share notes ahead of time, but we really need to check our biases, and looking at first and foremost the client autonomy and the client goals should come first in all that we do. We need to remember that they have the right to refuse or delay treatment if they're not ready to accept, and we have to respect those wishes. So it's often one of the first conversations I have with people is, again, from the panel this morning, what are you aware of your disease? What do you know of it? Of course, most people will say, it's a death sentence, it's terrible, it's horrible, or then some people will just say, I know the ice bucket challenge. So they really don't know more about what happens. And then I always ask, how much are you ready to learn? Like, what type of person are you at looking at problem solving? Are you the person that wants to plan ahead all the time? Do you want to know everything? What do you want to know? So I want to make sure that I'm giving them information in bits and pieces that they can absorb. And if they say, no, I only want to know things as it comes, then I'll say, so who's in your support system? And who is the planner in your support system? would you give them permission to talk with us so that we can help them stay ahead so that we're not caught when the bottom might fall out? And so most people will help with that. They'll identify either a spouse or a sibling or an adult child. Many times somebody will self-identify and call us at the chapter and they want to talk about their friend. And again, we have to say we really need to get your loved one, your friend, on board with this, and we would be happy to do this through a Zoom meeting, a phone call, a conference call. If you're close enough and healthy enough and everyone is well enough, we could do that in a home visit. Again, we also, as we've already heard, being mindful of our own biases around end of life. And remembering the boundaries, because it's hard and it's tough what we do. And you never know when somebody may share a nugget of information that you were not ready to hear at 5 p.m. on Friday, and you're going to get home because you have tickets to the baseball game. And you're sitting with the family, teaching them how to use the communication device and just checking in, and a sister is in town from out of town, and the person shares that in my communication device, I have all the information of what songs I want for my funeral, where I want everything, what kind of flowers, what colors, and nobody in the family had ever even opened up that conversation. So as Amber said earlier, you are the professionals and you are qualified, and mostly it's just listening and guiding and helping them to communicate with their family members. So the goal here is we're going to run to that target and hopefully find some good strategies and some takeaways that you can make communication first in all that you do with our families, no matter if you're a speech pathologist. I saw the social worker people raising their hands, and hopefully get some ideas and get some share boards going and putting communication first and having us adapt our goals and our meetings to what they need. The other reason that this talk came out is from our good friend Melissa from the Alabama chapter. And in May of this past year, she'll be talking a little bit in the next session about mental health providers. And so it was like the trifecta. It was May is Speech and Language Hearing Month in the US. It's also May is ALS Awareness Month, and it was also Mental Health Awareness Month. So this is a modified talk from there to a lot of the mental health care professionals, and how do you, and some of the talks that we were saying is, how do you do talk therapy with somebody who can't talk? So hopefully there'll be some good nuggets from here and we can have some conversation. So we all know that the barriers for communication are the speech production issues. There's a lot of emotion, normal emotion and exaggerated emotion. So the PBA, we could be dealing with some of the frontal temporal lobe dementia. We could be dealing with different cognitive issues, really looking at, lack of filters and apathy. All of those things are barriers to conversation. But again, looking at the self-determination and with the goal of improving their quality of life, giving them access to information, maintaining social closeness with their friends and family, and putting them in control of what they want for their medical care. And that piece on the reducing caregiver burden and the quality of life makes me think of a family, and I'll try to get through without my voice cracking on this one. They were very long-term, about 13 years with ALS, had adapted all the way through. Her husband was in the military, amazingly supportive, adapted to everything. To him, there was no problem they couldn't overcome. They just needed to adapt to it, get the medical professionals. So we can't swallow anymore, we'll get a feeding tube. We can't walk anymore, we'll use a wheelchair. She was having a lot more problems with her breathing and was 24/7 on her non-invasive BiPAP, was not enough, and they did opt for tracheostomy ventilator. Hopefully I probably shouldn't say the name of their walk team because that would probably betray some confidentiality, but lead it to say like they were not going to give up on things. And I could see that this maybe was going to be a problem because I could see where the client herself was not really sure that this was matching her quality of life. She was a biker, a marathon runner. They were extremely active. Large families from all the different places and friends that they had lived in the military. And you could see that while she adjusted to being there for her husband and her children, that there was still the piece that it was very hard for her because she was missing so much on doing all of the biking and running and everything. And it came to a head the one summer when she was at our ALS gala, and she noticed in the pictures that that's not even me. I can't even smile anymore. And so she would bring up conversations sometimes about, I don't think I can do this forever, and at what point would I need to, or wanting to open a conversation about withdrawal of her invasive tracheostomy ventilation. And each time, of course, her husband would kind of talk her out of that and things. So in this case, because she had her eye gaze communication device, because she had access to email, and because she had access to my chart, she was able to email her pulmonologist, who then called her husband and said, "You need to come in. We need to talk about this. Your wife is telling me that this is no longer a quality of life she cares to maintain and wants to remove the life support and discontinue use of a life. And so, of course, huge emotions and things, but we check in with him still all the time. But without that eye gaze communication device, without access to all of those things, she would not have been able to make her wishes known. And again, she had her funeral all planned, she had the colors, she even designed the walk team for the t-shirt for the next year. She had a whole list of everything that the family was supposed to do for the next year. So I think what we have to think about often is, as Amber said, we deal with this every day, and we do get desensitized, and we tend to see behaviors exhibited, and maybe we're misinterpreting what those behaviors are. So some of our own professional bias and at clinics will say, well, they're pleasantly non-compliant. They don't want to follow through with any of those things. So is it stubbornness? Is it rigid thinking? Is it inflexibility? Is it something more? Is it grief, acceptance? Is it when we had new team members in our clinic, there was a fine line of having them understand the difference between normal feelings and crying and the wailing, I can't stop crying, and it's going to take me 20 minutes to get ready for the next switch in the multidisciplinary clinic. Sometimes we would hear therapists say that they were resistant to therapy, or again, the poor compliance. And really not getting into the point of asking them how well they were accepting and adjusting to the diagnosis and understanding some of the tools that could be available to them. Many times, if you're obviously having problems with your speech and the bulbar onset, you have very flaccid face. They could be mistaken for somebody who has a severe cognitive deficit and maybe some frontal temporal lobe issues, but they just don't have the facial expressions to engage with you again. So again, watching mean that a flaccid face doesn't mean that they're disinterested or aloof. And I think it's really up to us as the professionals to somehow adapt. We adapt our houses, we adapt our clinics, we make sure that they're wheelchair accessible. The onus is on us to make our sessions and our visits with them, adapt them, and we meet them more than halfway. And I'm gonna give some ideas and some strategies, I hope. And if you all have a speech pathology graduate program nearby, reach out to them. They could make communication boards and do some programming and help gather together, and they would love it. So again, from Communication Matters, this article really, we talked about fatigue yesterday, and is it fatigue or tiredness or boredom or depression? And if we don't put patients, people living with ALS and MND, in the driver's seat to control their environment of their communication, we are not helping with their preservation of their psychological well-being. So the autonomy and giving them the option to communicate on their own without having a family member translate is imperative. And so we were talking at lunch, and having that caregiver who's used to doing all the speaking hold back a little bit so that the person can communicate. Having the neurologist or the team actually try to do more, have a little bit more time to give the person a chance to write out. Not everybody is as fast as Felipe over there. He's amazing. So while we know that 80 to 95% of people are going to be communication challenged at some point, and then we always get into like high tech, low tech, no tech, I'm like everything, anything. We have facial expression. You know, if you think about, and hopefully this isn't being biased and gender biased, but the mom look, you know, you've got that mom look down, lots of you know. So there's facial expressions, there's gestures, there's so many things that we can do, and so it's not one or other. And sometimes so many people they need an eye gaze device, they need a computer, they need this, and like, well, they need a multimodal system. So really focusing on what works in one situation probably doesn't work in others. So I guess first and foremost with this part, oh my goodness, that went fast, Miss Sarah, is really looking at the family or the patient and asking them what do they prefer of communication, making sure you understand everybody has a different yes, no, and communication for I don't know. We can't just have yes and no. We have to have an I don't know and I need more information. The forced choice is not giving them options for communication. So I'm going to skip through here. Again, you guys already know these parts.
You're good. You can, if you want to just keep talking, you just won't have time for questions. You
Okay.
do have
well, that
4
might be
minutes.
good. But Felipe already told me he was going to ask me a bunch of questions.
Oh, there's a plant in the audience.
So one of the things that I think is a great strategy is making sure that you provide an agenda for your session and I know everyone at our clinic is so exhausted of filling out that pre-clinic questionnaire. And I know that not all of the therapists have a chance to look at what is the most important thing, and it's all like making sure they get the FRS answered, right? Because we have to have that. So if there's some way that you can focus it in on the family and on the person here, what's your biggest concern that we need to do here today? Even sending that out a week ahead of time so they can start to journal or give you information and email you. You really need to think about how the room is set up. Many people don't want you walking behind them to look at the screen. You need to maintain eye gaze and facial expression, contact. They're watching your reaction while they're typing and talking as well. So we need to maintain that normal face-to-face communication. So we already have, most people know these, but you'll be amazed at how many people forget or because of their nervousness in interacting with technology, they will be, and I heard this the other day at a facility, the staff comes in, you know, doesn't stay long enough for the person to write their message and they leave, and so they've lost that connectivity with human. So stay in the interaction, slow down, making sure that you're maintaining eye contact, don't check text messages, don't do emails, and making sure that you're there. You wouldn't do that to somebody else who was able to speak. So just basic things of having people to remember. And always remember that technology is unreliable, so you always have to have a backup. If people are not familiar with this article and our Australian friends, this is an amazing article from 2006, Beyond Speech Alone, and has many, many strategies and considerations, especially for mental health counselors and how to set up and how to worry about doing talk therapy for people that can't talk. What I wanted to jump to, though, in our time, were some of these report cards and the fillable forms. This is just an example of making sure that either, obviously this is not all that accessible, but if they have it ahead of time, they could type in their notes section, and the speech pathologist would be great to make sure that they have their notes and things of what's their most important thing that they want to talk about at that clinic visit. How are they feeling overall? And those forms can be easily adapted. And so besides the panel that we had this morning, this is a serious illness conversation guide that all of our staff at our chapter either came from our local hospice or did a training with us on the serious illness conversation guide. And it really focuses on setting up the conversation, again, looking to see what they're ready for, how much information they want, what type of information, and then saying, so many people are, I don't really want to do the eye gaze communication device. I'm hoping that when I can no longer talk, I can no longer breathe. So we hear that, and I'm like, that's a great plan, but it may not happen that way. So how about if we start using some technology so that you have a backup? And so there's many, many, many resources for free communication strategies and communication boards, thanks to my friends John Costello and Amy and Elisa, who will talk more about those. Lots of clickable, hopefully, links that would be helpful for everyone across the, here and across the United States and across the world. Some of you people, how many, a show of hands, are people familiar with Patrick's legacy in the eye gaze? Probably most of the speech pathology friends over there. So there's a great video. Reach out to me if you want to know more, and it's very easy to set this up and use and have it in a desk drawer if the technology breaks. So here's more resources. Here's some videos so that you can take to your hospice team, your home care team, using very simple things that you could find even at Dollar General. For those in the US, they're everywhere now. They used to be my Radio Shack and my Walmart fans, but now I find Dollar General with cat lasers everywhere if we need that. So, and some great articles, so if you need some references. So, thank you.
All right. This presentation is now open for questions.
Of course.
Felipe.
Hi, I promised a question. Here it is. Getting used to eye gaze needs time and patience. Should people living with ALS, MND have an eye gaze communicator before losing their voice?
So here in the US, that's a very big challenge. Insurance won't pay for that type of technology until you demonstrate the need. So it has to be a least restrictive, least costly device. So you have to demonstrate that they are no longer able to use direct access with hand, mouse, any of those direct access methods before you can get to eye gaze. The good news is that so much of the add-on eye gaze technology is much more affordable than it used to be, and so many of the software programs can be downloaded for free on your tablets and have, as long as it's full Windows, and you can be trying out lots of those things ahead of time. Not everyone is willing to start learning those things ahead of time, and that's the biggest challenge. So by the time they're really ready to start talking about it, and having, one of the articles in the link is 90 days is a good lead on getting that from from the speech pathologist and the vendor and things. So in 3 months when they're finally ready, so they're often using loaner programs, loaner devices from chapters and things while they're waiting for their own. That's a great one. Anyone else?
Any other questions? Oh, there's an online question.
All righty. Patty's getting her steps.
Do you collaborate with occupational therapy to ensure that the communication device is accessible in all environments?
Okay, that's a great question. I'm gonna channel Lisa Bardock, and I hope she's listening. Yes, it would be ideal to have occupational therapists to do this. My graduate program was at University of Wisconsin-Madison, and I have the technology with OT-PTs, rehab engineers, and speech for learning cross-training on those things. I don't think it takes, an occupational therapist to show somebody that they can't move their hand or their arm. So I think we can do that part as well. But it's definitely making sure that I think that's part of what we do. We have to document if they're in their wheelchair, if they're in their lift chair, if they're in their hospital bed. And yes, we definitely have to make sure that they can access that device and all. The problem is often insurance not paying for more than one mount. So again, back to chapters and loan programs and things.
If it's a quick question.
How do you manage frustration with patients that are not that tech savvy at first with eye gaze communication?
So eye gaze isn't for everybody. And if they can't manage that, and so we use a lot of the low tech or the no tech things. Many people still have hand function or even prefer, it's normalized to carry their cell phone around. And so many people can still use their cell phone apps. We work with what they want. We might have lots of different boards around the room for look over here and then ask it's one of these things. So it's hard. I mean, the whole environment with whoever the caregiver is and the staff and our folks that live in nursing homes, care centers, is tough. Like right now they're using agency staff and there's 3 new people every day. And we're resorting back to the old, put a piece of yarn on the device and put it to the tip of the nose. That's how far away from them it needs to be, or tape on the floor. So it's tough, and getting calls every day. So somebody in the nursing home has to be the lead person to be able to learn that. But it's tough. Like, the safety is really a huge issue.
All right, I'm giving you that mom look.
Yeah.
Let's all say thank you to Lisa.